Good afternoon. I'm Gillian Leng. I'm the new Dean of the Royal Society of Medicine, and I must start with an apology if any of you dialed in at 12:30 and didn't get the email about the time change. I'm really pleased that you're here now. I'm delighted to welcome Dame Jenny Harries to episode 107 of the RSM's COVID-19 Series. And I'm sure Jenny is well known to many of you as the Chief Executive of the UK Health Security Agency, and therefore in a pole position to know all there is to know about the evolution pandemic. We've got an hour to talk about the evolving fourth wave and the emerging research. And I'm going to kick things off, but please put your questions into the Q&A, as it's really important that this is an interactive session. And I'm expecting quite a lot of questions, so I probably won't ask them verbatim, and we'll try to combine themes wherever possible. So Jenny, I've been lucky enough to go to several international conferences lately, and it's clear that in some countries the message is that the pandemic's all over, whereas in others it's still a serious business. How should we be feeling in the UK now?
So I've also done some of my very first trips overseas in recent weeks, and I concur with that. And I think it's not only just the countries, it's the different groups of individuals in those countries. The pandemic very definitely isn't over if we're looking at the way the virus is changing. We've got a number of variants, and we'll probably talk about those. But what we are seeing is perhaps a much higher degree of uncertainty. So in the first phase of the pandemic, we saw very significant rises, a new variant and a big increase of growth advantage, and then down again. What we're seeing now is large numbers of different variants, sometimes just competing with each other, as we have done recently. So if we look at the UK, but actually similar patterns across Europe and in the US, we've still actually got a slight growth increase in numbers of infections, but those fortunately in the over 70s now have started to plateau off and just starting to decline. And we've seen that preceding us, perhaps in the US, but also similar patterns across Europe, as I say. When you look at some of the variants, that we've had a BA5 wave recently, I think we're probably just about peaking out on that, with levels of hospitalisation which have been similar or just a bit below that in the summer. I think the real uncertainty here is what is going to happen as we go forward. Importantly, of course, our testing is different now. So we have pretty good granular data, probably some of the best in the world, but it's not quite the same data that we had before, because we are not testing quite as many members of the public. So there's a bit of a lag in some of the variant detection. And we have to remember that we're looking retrospectively. So every time you go onto the dashboard, COVID dashboard, and see ONS data from our survey, it's looking retrospectively, and we need to think through what that means, what we're seeing coming into hospital, and also recognising that COVID-related deaths will still be happening 2 or 3 weeks after the infection as well. So I think definitely not over. BA5 wave, hopefully plateauing, subsiding. Lots of interesting variants coming through, which we're watching, mostly Omicron ones, but some of them of different lineages now. And we need to keep watching that as we go forward.
So in terms of the winter, some people have been describing a twindemic, the combination of COVID and a more severe flu season, which I think they've had recently, haven't they, in Australia. So should we be expecting this really difficult winter for the NHS?
So I think the really difficult thing is we can't expect anything. We can be anxious about, and I think that's exactly what we should be. So the word twendemic is not a guaranteed position for the winter, but it's one that we reasonably should be planning for. As you said, in Australia, what they saw was an H3N2 flu wave. It came earlier in the season than it would normally, so sort of April at their end through the next couple of months, usually probably starting in June, so it's a couple of months earlier. It left larger numbers of children in hospital and very high rates of flu cases in children. And of course, many of those younger children have not been previously exposed during periods where there would be normal socialising. So I think what we've got now is people who are fairly well protected from COVID, and I'm sure you'll let me do a plug shortly for COVID and flu vaccines, with opportunities to get both the boosters and their flu vaccines now. But we can't predict the exact timing, so it's quite possible, for example, to have both of those rising at the same time. It could be that we have one peak followed by another, which will put substantial pressure on health services, and we might see slightly unusual patterns, for example, as I say, in younger children, when we tend to think of flu predominantly affecting older individuals. So a twindemic is still possible, and I think it's the combination of the control measures we've got, how well there is, how good the uptake is for vaccination as we go forward over the next few weeks. And then obviously we do have to think through about waning in vaccines, but if people are going out to get their vaccines now, that should hopefully be covering the worst of the period when we will be tending to stay indoors for most of our socialising.
So in terms of the winter, be prepared for anything, I think was perhaps a bad précis of what you said. But in terms of vaccination, and you mentioned that rates were coming down in the over 70s, are vaccination rates as good as they were initially? And are we planning on offering vaccination to any additional groups?
Yeah, so people who are listening in may have seen we've we've just gone out with a big push on COVID and flu vaccines just over the weekend and the start of this week. So now both of those boosters, the flu vaccination and the COVID booster, are available for 50-year-olds and above, plus of course the other groups that we really want to protect. In the 50 and above, we've got about heading for, I think, 36% at the last time of all over 50-year-olds vaccinated, a proportionately higher amount in the 70 plus, and really, really good coverage in care home residents. So I think we have reason to be optimistic about many of the individuals who are at highest risk. The two areas where I would promote, I think, in supporting, partly because of that narrative of what's happened in Australia over their winter period, is to ensure that younger children, infant school and preschool, and some of the younger ages in secondary school are coming forward for nasal flu vaccinations, as we approach the winter. But really importantly, the group that somehow we never quite manage, I think, to support into getting their vaccination are the middle-age group with underlying health conditions. So 5 to 49 in COVID and younger age group to 49 in flu. So I think that's the important group. There is some suggestion that people have got a bit tired of vaccination. I don't think we can yet say that. We've had very good uptake in the very oldest group of individuals, and so we'll obviously be keeping an eye on that as we go forward, and we do behavioural science studies on that to check where the uptake is. Again, importantly, we're trying really hard to learn from the pandemic and some of the really innovative ways of reaching out to people, particularly those communities who are less confident in receiving the vaccine, to make sure that it's delivered in a way that is easy for them to access, but importantly, comes with trusted voices who can explain to them whatever they need to know. And so lots of work going on with local communities, Directorate of Public Health, and a new booking system for flu also with the NHS.
Well, that's an important plug, and I gather there are some journalists, members of the press, listening. So if we can all do our bits to encourage uptake, that would be great. I'm just turning to the Q&A, and there's a question about protecting the immunocompromised who don't mount a good response to the vaccines. Any thoughts on that? Because the questioner says shielding alone cannot be the answer.
Yeah, so for absolute clarity, there is no recommendation to shield at the moment. That was taken out a long time ago, and I think that's important because right the way through, well, all infectious disease management, but particularly with this pandemic, because of the length of our learning period to understand how we can best control it, is that there are balances in psychological welfare, physical well-being, and protection against infectious disease. Actually, for a large proportion of those who are classified as immunocompromised, there is a response to vaccination. So I think key message is, unless you have been specifically advised not to have a vaccine, then actually that's the first thing that you should do. And we estimate probably somewhere between 80 to 90% do have a response. So it's not that there is no response to vaccination, but it is, and it's no different for COVID than perhaps with other infectious disease. So every time there's a flu season and individuals are going to get their flu vaccination, I think most of individuals in those groups, if they are perhaps having chemotherapy or have been immunosuppressed in other ways, they are generally advised to take care. And I think they should take that message from their treating clinician. But of course, what we do have now that we didn't have at the start, and when shielding was introduced and was available and recommended, is access to antiviral treatments, and indeed better outcomes from treating COVID infection itself. And so that particular group, we now, just from a programme perspective, I realise they're individuals in their communities, but we work with the NHS, with the Antiviral Task Force, for example, within a programme called the Enhanced Protection Programme, in order to ensure that we're continuously looking at what treatments or antivirals might be available or might come online, and then to ensure that testing is available to those individuals, that they get very early access and the best outcomes from treatment. And that process is still in play.
Thanks, Jenny. There's a few questions around data that I'll try and bring together, because you said earlier about the new dashboard, and there's a question about looking at data collected by Tim Spector and colleagues at King's College, which gives real-time data, and questions about wastewater virus surveillance. How do all of those things come together?
So I think in the early phase of the pandemic, in fact, we used Tim's work in the Zoe app. We used to monitor that regularly alongside testing data and indeed the wastewater surveillance data. And I think there's much that we can learn from that. But just having a stream of data in itself doesn't necessarily create an advantage. And one of the things which we are looking at as we go forward, and very much thinking proactively about biosecurity surveillance mechanisms, what does the combination of the information we have tell us, is around the value of each set of data and how it is best used. So wastewater is a very interesting approach. Obviously, we're using it currently to look at polio viruses, particularly in London, but also looking in other parts of the country to see if we can see any vaccine-derived polio virus there. It was used in COVID, and clearly you can detect virus that way. But what we really need to do is think very carefully about in which circumstances it adds to the decision-making process about advice or safety for different populations. That bit of work is still ongoing, and there's a recognised need to do more precise research, because often, just as a general thing, obviously taking a wastewater sample and finding some COVID virus, even of the interesting variant, tells you you've got a variant. It doesn't really say which population is at risk, and so you have to keep going backwards up your sewage pipe, so to speak, to check to see which population it is. So areas where it could be useful potentially in the future, for example, might be for early care home detection. If you can narrow down the source and your sampling. And so there's, for example, ongoing work with prisons and some research work ongoing. So that's an area we're absolutely actively looking for. With the Zoe app, again, it was interesting in, obviously you have to then adjust for the bias in the population. So Zoe app was very much a younger population, which is good because they sometimes don't necessarily give us all of the information we want through other means. But overall, we don't routinely look at that now. We're using a very consistent ONS survey, which gives proportionate representation of the population.
That sounds like all avenues, including the sewage pipes, are being explored to give us some really good data. In terms of checking the virus, the media has described a swarm of new COVID variants. Is there any signs of a new variant emerging that might change things significantly? And there's a question about the vaccines keeping up with this evolution of new variants.
Yeah, so there are three things there actually. With all due respect to my journalist colleagues, a swarm conjures up a very active picture, and I think these variants are active. I don't think they are necessarily swarming across all of our populations. It is entirely true that there are a number of variants coming through, and for people who really want to digest all the different ones, because I could be here for some time reading them off with the right pieces of paper, UKHSA produces a technical briefing. The last one that's published is number 46, I think, but if you wait till Friday, hot off the press, you will find number 47, which will give you the next insight. What we are seeing is about 3 Omicron backbone variants coming through, which we're keeping an eye on. And then there are some reports from overseas, but where we have seen a few cases here. So, for example, XBB, which is a combination of Omicron and earlier variants. Now, some of those are showing a degree of enhanced growth in comparison to BA5. And the XBB one, particularly in Singapore, has been, but not necessarily, it's been found here, it's been found in other European countries, not necessarily displaying exactly the same advanced growth rate. So with all of these ones, we keep monitoring them. UKHSA at its Porton Down site does neutralisation studies with serum from patients who've been exposed previously to infection and vaccination. And we look at then the effectiveness of our current vaccines, so that if we spot an issue, particularly those where we're concerned that the structural biology of the variant may indicate an enhanced risk of immune escape, then we are looking at those intently. One of the issues, though, obviously, as we go forward, is you need to have a sufficient number of samples and sufficient clinical information to actually understand that. So probably around 1,000 samples, and to get a really robust picture. And so inevitably you will see ourselves or our journalists reporting different variants which are being posted on GizAid, on the genomic platform internationally, which is accessible, but then you won't get robust information of the clinical impact of that until several weeks later. But for assurance of colleagues listening in, that piece of work goes on all the time in the background at Porton Down.
There's a sort of related question that's popping up a number of times, which is how well are we prepared for the next pandemic? And that's always the risk, isn't it? You focus on what you've got now, what you've had last. So are you confident? I'm sure you say you are, but how confident are you for managing the next pandemic, whatever that might be?
Well, probably the biggest risk is if that we are all confident, because we won't be looking for all of the opportunities. And I do think it's said often, but we absolutely have to learn from the pandemic now. It's been hopefully a lifetime experience, a once in a lifetime experience for most of us. And particularly my responsibility is to ensure that systems are as good as they can be going forward. So I think there's what have we got ready for this pandemic now in case it resurges? And there are a number of things we've got, and we've got tools we didn't have. So we have lateral flow tests, for example, which again we keep checking against variants, but broadly are likely to be useful if we have a surge. So again, not requiring quite the same measures in numbers of PCR tests. And of course, we are continuously developing new therapies and vaccines. And as you flagged, this time the UK booster this year for COVID for this winter is a bivalent vaccine. So it has BA2 and it has the original, I'm going to say Wuhan, that's probably not a politically correct variety, but what we would call the wild type variant in it as well. What's interesting as we go forward, and this is a principle I think we need to think for other potential pathogens that may cause pandemics, is trying to understand whether the brilliant new technology of very focused attack, if you like, on different variants through mRNA is a requirement, is the right way to go to get the best results. And we do see slightly better impact, effectiveness against Omicron with the new mRNA variant vaccines. Or actually, and this is the other side of it, it's a big sort of scientific question at the moment, whether the breadth of immunity that builds up actually gives sufficient effectiveness against very severe death, very severe disease outcomes and death. And that question remains a little bit unanswered, because we're seeing, I mean, each of us are walking around a bit, like a sort of museum of COVID at the moment. So if I take myself personally, I've had a couple of AstraZeneca jabs, I've had a couple of mRNA jabs, I've had, I think, 3 variants of COVID, 1 badly, 2 I hardly noticed. And we will all have our own different immune strength now in relation to COVID coming forward. Going to your question about are we prepared? So I think there's lessons about responding. So, being able, for example, to trigger a new vaccine very quickly, which is directly able to handle a new pathogen. And I think there is hope for us to do that going forward. And we see that in the G7 ambition around a variant of vaccine in 100 days. And so some of the things we're doing, just this morning I was on a phone call with MHRA, medicines regulator, because what we saw in the pandemic was not a change in what we do, but just a condensing of it, because everybody was so focused. So there are ways of getting those vaccines, which are likely to be treatments we'd want in closer time. There are ways of working ethically and appropriately with the pharmaceutical industry to always be horizon scanning for public health need and products that might be coming through pipelines. And then there's a very practical point about maintaining relationships always open with local authorities, with directors of public health, with colleagues in the NHS, to ensure that when we have to trigger into a response mode, everybody knows what their roles and responsibilities are. And, there's work ongoing on that, but I think we've learned a lot and would trigger them much more successfully going forward.
And in terms of local public health systems, there's a question that's floated to the top of the pile about what message would you like to give to Steve Barclay, who of course is the newly reappointed health minister, about funding for our public health systems.
On the morn of a new government, and as a very senior civil servant, I'm sure you will understand and will be particularly careful about how I phrase this. But actually, what I'm here to do is to protect the public and put a public health professional view forward. And clearly, in fact, I don't think I need to say this to our new Secretary of State, because it is very obvious to the nation why health security is so important. And it isn't just about, although this is absolutely critical, the well-being, if you like, in physical sense terms of hospitalizations, and very sadly, as we've seen, deaths through a pandemic, but it's the much wider impact. So the immediate secondary impact on health services, in the sense that if you're dealing with COVID or whatever the next pandemic is, you will never have a country which has sufficient capacity to respond to everything. And so you have to prioritize that. And then the much wider issues about things like mental health and well-being, particularly seeing that in children and young people, I think, in educational sustainment as you go through these things, and then the wider impacts on the economy. So, fortunately, I think, unfortunately for us as a population and global population, probably the one message I would have wanted to have given previous secretaries of state prior to early 2020, I don't think I need to give to this particular one. He will be very well aware and has contributed and led many of the discussions at national government level around responding to the pandemic.
Well, that's reassuring, actually, Jenny. And I'm going to go back to vaccines, because a number of questions about vaccines, and one perhaps relates to what you described as a patchwork immunity to various different variants. There's a question about the choice of the vaccine that's being used. I think it's largely Moderna, isn't it, that we've rolled out. Why that one? And then there's a question around boosters. Are we all going to have boosters annually from now on?
So on the vaccine, so in the UK we have MHRA approval for vaccines from Moderna and Pfizer, and those are the ones which are being rolled out. I mean, the critical message here is actually just get a booster is the bottom line, even if it's the old wild type, because what we see is the majority impact is in getting the booster and boosting your immunity. As I said previously, there are advantages currently on current effectiveness data around using these bivalent products to target Omicron, which of course was not around when we had the original set of vaccinations. And so it is particularly important for those in the high risk groups, for the elderly, and obviously we've got a national programme which recognises that in promoting it for everybody 50 and over. So I think that is the key message. And I've forgotten the second part of your question, Jill, so perhaps you could remind me.
Do you think that we'll be having boosters every year from now on in?
Yes, so I think that is, I think there is, who is we? Is it the whole population? Is it a subset? And then will it be every year, every quarter? I mean, what we've seen so far is, in many of these cases, you can see, particularly in the elderly, there's a change as you become older. You're less likely to sustain high levels of antibodies as you get older, and therefore, for many of those at the very oldest age groups, we have seen three-month waning, but actually still pretty good protection at 6 months. And if you really roll it out and look, you can still see that at about 9 or 10 months. So I think one of the conversations going forward is for us all to be absolutely clear what it is our end point as a society. And I think I've been lucky enough to be involved in some really interesting conversations at the Vaccine World Congress in Barcelona a couple of weeks ago, and again at our own UKHSA conference last week, on global discussions with pharmaceutical industries, you know, those who are technically making the vaccines, but then equally the practicalities of delivering them, because there is no point having a brilliant vaccine and a booster available if your population don't see the point of taking it or are unwilling to. So I think we need to think right through that whole pathway. I think it is likely that we will be wanting to boost those whose immunity wanes relatively quickly and who are highly susceptible to severe outcomes. And in general, for this particular pathogen, it seems to be those at the older age groups. But I think too, you know, I can't get tied into a box on that one, because I think we should be looking at the evidence, and we're still growing the evidence on this.
Well, one more vaccine question, then there's a few about masks, so we'll do those in a moment. But the other vaccine question is, do you recommend the booster vaccine for long COVID and vaccine injured patients?
So again, I think still lots of learning to do with this, both on long COVID itself. I mean, I think we've made good progress, and there's been a focus in this country. We've been quite ahead of other countries, and recognise that this is a severe impact on individuals' lives. And actually, to the extent, I think we're talking around 1.6 million by ONS figures of individuals who have some sequelae at 4 weeks plus from COVID infection. So this is a large number of people, and not necessarily linked to the severity of their illness. So younger people who've been very active and suddenly are really knocked down with this. The evidence to date suggests that vaccination is certainly not harmful and may well be beneficial. But again, I think because it's quite difficult to separate out, if you like, sub-cohorts of those who have long COVID, we still need to learn more about the interaction of the vaccine with the illness, and what the different parameters mean, and what the risk factors are for different manifestations of it. But certainly at the moment, vaccine is good, because I think people were worried at the start that it might actually make things worse. But overall, a positive mood, but still more learning.
Okay, well, that's good to know. There may well be some clinicians on the webinar wondering what they should be advising their patients to do. So wearing a mask. Do you wear one in enclosed public spaces, Jenny? And what do you think is likely to happen if we have a COVID surge this winter? Are we likely to be advising face coverings again? And what type? Somebody's pointed out that they think there's evidence that more effective masks are FFP2, as advised in Germany.
So this is really difficult, as we all know, and I can see you smiling at the screen. And my first question is going to be, do you mean, do I wear a surgical face mask, or do I wear a face covering, and how many plies of face covering do I have, and in which particular circumstances under ventilatory conditions do I wear it? So, I mean, my general rule is, if I'm in a clinical setting where prior to COVID, one would normally have worn a medical grade face mask for appropriate interventions, so high risk exposures or whatever it might be, then of course people continue to wear them there. In relation to COVID, what we are currently saying is that individuals who are infectious, I mean, one of the things I think we have learned is, and this doesn't just apply to COVID, I think this whole episode is making us rethink what our advice is. So if you have COVID and you're symptomatic, or you know you have COVID, even if you're asymptomatic, but equally, if you have another respiratory virus disease, as a patient actually putting it on means you are protecting others from receiving to transmitting to others. So I think we don't normally advise that in this country, and I think that is a change, and the evidence on that is very strong. I think through the pandemic we've got quite confused about whether it's an infection source control mechanism or a recipient safety mechanism, and we need to try and sort that out. We are advising generally in areas, so for example on specialist wards where you have immunocompromised individuals and those at highest risk of severe outcomes, to work them there, and then generally leaving that down in health and care settings to local discretion. And that doesn't just mean do what you like, it means have a bit of a risk assessment around the likely risk of transmission, including in the environmental context that you're working. And this is so important. So many times I'm asked at national level to almost do a prescription for some sort of infection prevention control measure. And of course, we can all imagine different hospital settings, probably, or care settings we've worked in. Some of them have absolutely superb turnover of airflow and a relatively low risk with very good ventilation, and social distancing is entirely possible. In others, it just isn't. And you can think of a modern hospital going to a Victorian institute to, a 60s DGH. And I think all of those things are much better assessed by the DIPSI, Director of Infection Prevention Control, the medical director, and gaining support for that and trust from staff in a setting around the rationale for why you're putting in measures, whether it be mask wearing or whether it is actually other infection control measures. One of the problems with this question, I find, and I have gone slightly off-piste, I realise, is people are either, it's almost become a polar discussion about masks, which then spreads out into a polar discussion on infection prevention control measures. Well, it's stopping through hospitals, or this is absolutely critical. Now, the right measures are always absolutely critical for safe care, particularly in health and care settings, in vulnerable settings. And so it has to be looked at in relation to the prevalent risk. So what's the infection rates around you? What are the environmental conditions which will affect transmission? And what are the risks of the patients or the people involved? And to go back to your original question, routinely, I'm not wearing one at the moment. I still do things like, I work in London most of the time, I still stand a metre or two back from somebody. If I'm waiting to cross the road, I always put one on. I have one in my bag if somebody is uncomfortable, or if, for example, where we've had high rates recently, I'm on a tube and it is quite cramped, then I will sometimes put one on them. But it's responding to the risk around me.
That's interesting. So do you think we need some new public health messages around mask wearing over the winter? Would that be helpful, bearing in mind that confusion you described?
Yeah, so it is very difficult for the reasons I've said to give a single message. What we know from the pandemic is that, and we've seen this in action, that where the public, and we're all professionals in that public, can see the rationale for a measure and we explain that appropriately, they usually make very good decisions. So the end of the last COVID wave, we could actually see on the data was tempered by the fact that as people watched the numbers rising, we know that they took more behavioural precautions. And in many ways, the population managed the peak of that pandemic without any direct required interventions. Now, clearly in some settings, for some vulnerable groups, we have to make protective interventions, but as a general principle, I think you're right. I think we need to give clearer messaging, and in fact on the face coverings we actually do have a review at the moment ongoing in UKHSA to see if there is any more definitive evidence that we can put into a better message, both for the predominantly actually it was requested for the healthcare system, but I think it would obviously translate through to the general public as well.
Because as is the case with all messages, be they public health or anything else, the more straightforward they are, like wear a mask or not, they're more easy than the nuanced complex ones, even though the nuanced complex one is probably more accurate. I'm going to ask a slightly different question because there's an interesting one here that I like. It's about the business community and what the business community can do to manage and reduce the risk of COVID and flu. And is the UKHSA planning to work with businesses because they might help access working age populations? And you mentioned that group not getting vaccinated. So,
so some of my very best and most productive early engagements in the pandemic actually with the Faculty of Occupational Medicine. Now, some of that started with appropriate advice for healthcare workers, particularly in hospitals, because that was probably the area that was most apparent. But of course, what we know from general public health knowledge about disease transmission, but have particularly seen during the pandemic, are that certain industries and businesses are potentially more prone to transmission. So the one meat processing plants, is not the first thing probably that would jump to the public's mind, unless you own one, and then you know that there's a significant risk. And I think there is great opportunity. We have done guidance through this to try and help that, because quite simple measures like putting up plastic sheets, if you like, when people are facing each other across the production line, will start to decrease that. And then probably strengthened advice drawn from many of the environmental studies that are still ongoing around respiratory transmission can also be fed back into those industries. So yes, I think it's actually a great place to go for wider learning, and it has both the advantage of obviously helping the individuals themselves, but maintaining safer business continuity through what can otherwise be a significant impact of a pandemic. The only thing I would say is there are a number of other things which we perhaps don't think of are in the ring around the business. So if you take that example, it's a coldish, dampish climate and people work directly opposite each other, but there are other factors that are really important. So many people working on those production lines are fairly low paid workers. Many of them actually in our findings were living in houses of multiple occupation, often in quite cramped conditions. And even in other industries or working environments, people would lift share and come into work. And of course, an enclosed car with all the windows sealed up at a peak of a pandemic is quite likely to be a very highly effective transmitting area. And so we need to think through these, and particularly as we go into a winter where people will be trying to keep the heat into the vehicle or their houses. If we have one or both of those bits of the twendemic, then those are some of the risks, I think, that we have to think about.
Yeah, that's a good point about keeping the warmth in, especially this year with fuel being so expensive. And there's a question here about ventilation, actually. Is the UK doing enough to improve ventilation? And they mentioned schools, hospitals and other public buildings. So
Professor Kath Noakes, who actually led a group looking at environmental factors in transmission for SAGE, the expert advisory group, is still doing work on this, and I think there probably is more that we can do as a nation, but it needs to be fed into other health security risks as well. So, you know, climate change, it starts to become slightly overpowering as you work through all the different risks. But I think building adaptations and thinking through, both in terms of, I mean, we're well outside COVID now, but, you know, thinking through issues of ventilation around infectious diseases, but also efficiency in terms of sustainability and impacts of climate change or what have you, that there is perhaps an area where we haven't looked at with a health lens before. And I think we are starting to do that now.
Just found a really technical question and it slipped by. It's about coagulopathy. Here we are. Yeah, so again, changing tack slightly. As microclotting was a major factor with the high mortality that we saw with the original virus, but then not with Delta or Omicron. Should we be monitoring D-dimer levels to make sure new mutants don't also cause this clotting? Perhaps we are, Jenny, perhaps you're going to say we already are.
Well, so I can do a lot of things from my public health office in London, but this might be one of those ones where if my colleague, Professor Stephen Powis, was sitting alongside me, I would hand the question to him. I think what I can, so I can't answer the question directly, I think. I would have to go and do a little bit of checking. But what we do is there are a number of studies ongoing, which are longitudinal studies looking at various factors of impact, clinical factors in terms of patient care. They are not directly coming into the UKHSA, which is why I'm being a little bit hesitant to go into the detail of this. But I'm pretty confident they are being monitored. And in fact, in the very early days of the pandemic, there is a system set up called ISARIC, so that very early data can be shared without barriers of data sharing, or entirely ethically and confidentially, to ensure that we can look at some of these potential risk factors which are peculiar to a new pathogen as it expresses itself in clinical cases. So and many of those particular issues, and I think this is one of them, are picked up in longitudinal studies then, so that it will be put through bids for funding for very specific research programs. So if you would like to catch the name of that individual separately and email me, Jill, I can see if I can get them a more detailed answer back.
Okay, thanks. I'll try and stick to more core public health questions. There's a couple, I'm going back to vaccination, but there's a couple about pregnancy, and one is a general one, are rates in pregnant women improving? And then there's something that reminds us that immunity from the jab seems to only last 3 to 5 months. So when should a pregnant woman be jabbed to protect both her and her infant? Is there a timing issue with that?
Yes, so I mean, I probably sound like I'm repeating myself, but I think there's still a lot to learn in this. I mean, one of the issues which I think we all recognise is at the start of a pandemic or with a new treatment, one always takes, I think, quite rightly and ethically, a precautionary approach. And so pregnant women, when you are concerned about fetal development or what have you, it will always be a precautionary approach to ensure that both mother and baby are adequately protected. And it's the risk balance for many of these things. And of course, actually what we've seen in this pandemic is probably heightened concern because we have no research data trial data at the start of the pandemic. So women were generally not put forward simply because there was an absence of data, not because it was negative. And then what we have seen is the sad impact of COVID on cases, particularly in later pregnancy. And I think, again, there's some learning from this that we need to take into our plans going forward for advice. It's quite difficult because often what you're doing is, yes, we are boosting now. The question about the uptake is still quite low. It's one of the groups, along with younger women, younger people with underlying health conditions. There's still a group that we are not reaching, and I think some of that stems from the fact that there was uncertainty at the start of the pandemic, so people feel less comfortable then that it is a safe thing for them to do. Absolutely everything says this is a safe thing to do. In fact, it's quite unsafe if you don't protect yourself in comparison to having a vaccine. So that bit is very clear now. I think the actual timing of it is often, as I said earlier, the 3-5 month waning period. In actual fact, for most vaccines, there is pretty good coverage for a longer period of that against very severe infections. So although you'll start to see this waning, you still do retain some infection. So clearly the heightened risk period is the 3rd trimester. But I don't think anybody would be advising women not to get vaccinated in order to pinpoint it. And then, because if you happen to become infected earlier in the cycle, that might have been the wrong thing to do.
And are the rates in pregnant women improving as we're now clearer about the safety?
They have improved slightly. I don't have the current rates with me. They have improved slightly over the pandemic. I don't think they're necessarily particularly high just at this point. Obviously, we're just going into a booster campaign again, and we only kicked that off in a big way over this weekend. Many colleagues have done, so the Royal College of Obstetrics and Gynecologists have really done some fabulous talks on this. They've been very proactive in the media. And in fact, the Chief Scientific Advisor, Lucy Chappell, is an obstetrician by background. And so she's been particularly active in going out to various channels when we do this, not the obvious medical ones, Mumsnet and various other things, to try and support that and really answer questions from that group of individuals. Often, once a sizable proportion of them feel comfortable, they'll get a trusted message from somebody who's received it themselves. So I think we try and tackle that in different ways, but I think still work to do.
No. Well, we're moving towards the last 10 minutes. I'm going to be a bit more rigorous about asking the questions that have floated to the top of my list, because of course if people like the questions, then they come up to the top. And you might say the one at the top is for Steve Powis, Jenny, I'm not sure, but I'll ask it anyway. What about Evusheld to help protect the immune compromised?
Yes, I was sort of anticipating that might come up. So I can do a little bit of a disclaimer in the sense it isn't the role that UKHSA plays. Actually, we are commissioned by different pharmaceutical companies in our specialist labs to do various studies, and we have contributed to those, and that's just a normal commissioning process. But of course, what I would like to think is people will feel comfortable that very good and independent study has gone into those responses on neutralisation studies. There are a number of different treatments that have been proposed through the pandemic, particularly to assist. And I know I personally speak reasonably frequently to individuals or to organisations representing many of the individuals who have been very reasonably quite frightened through the pandemic and still feel that there isn't an end point for them in this, and there probably is for the rest of the population. So we have, as I mentioned before, the Enhanced Protection Programme, and the Evusheld and other antivirals come through the Antiviral and Therapeutics Task Force. And so any treatment, whether it be Evusheld or anything else, comes through and is assessed for effectiveness, cost effectiveness, and in comparison to other programs and processes to protect those individuals. Now, I will have to be quite careful about what I say here, obviously, but I think there is a difference between licensing a treatment as safe, as in not causing harm, and really promoting that as a cost-effective mechanism for addressing a population. And we are, I mean, just myself personally, as a physician, are really keen to make sure that wherever we can, we develop new treatments and we get them into the system as quickly as possible. But we also need to make sure all the right precautionary approaches are attached to that, and we have some consistency around how we compare them, and that we are using our resources that we have to ensure we've got effective treatments. And with Evershed, there have been studies, and they've been reported very much publicly, and I think a lot of direct promotion to some of the groups who are most concerned about their well-being. But when you actually look at some of the studies, which is the routine way to assess them, the comparators, for example, they are observational studies often, they have been against different variants, and some of the other parameters do not yet show significant effectiveness for use in the UK NHS. I think it's also important, and a question I can't answer, but I think anecdotally that although availability is high in other countries, that the actual uptake may not be quite as significant. And I don't know that. I'm just so I think it's important that that I state that. But we really need to distinguish between having things that are really effective for this population, which is what we absolutely want to do, and other treatments. And it's likely we're looking at some of these groups, the vaccine task force, the antiviral task force, going forward. The vaccine task force has actually come into the UK Health Security Agency exactly so that we can use exactly the same ways, agile response, and looking for new treatments and vaccines that we did before. And I think it's likely we'll play quite a significant role in the development of and encouragement of new antivirals as well going forward.
There's a question that's probably saying what you've just said. Anecdotally, people eligible for antivirals haven't received them, or at least haven't always received them. I imagine even people who were given priority PCR tests weren't able to access treatment as a result, and sort of ending up with, has demand outstripped supply, or is there a change to eligibility?
Yeah, so there is a testing access which we provide the test to ensure that individuals in these groups, in eligible groups, can get a test quickly and get treatment as quickly as possible. Obviously, early access to the antiviral is a really important thing, and everybody recognises that. I think the delivery through the CMDUs, through NHS systems, is a new mechanism for developing treatments and distributing it out to individuals. And I think the NHS are working to see if we can perfect that in some way to improve it. There is a really important learning point here. I actually chair a group which works with the NHS colleagues and with the Antiviral Task Force, and obviously with the provision of tests, to try and see how we can take this learning going forward. So in the event, it goes back to your earlier question, Jill, in the event of a new pandemic, some of these individuals are likely to be those at risk again. Can we instantly identify them to give them a very early appropriate advice, so that they're not sitting there anxious, or at least they know that somebody is thinking really hard about them and their particular clinical conditions? Can we learn, perfect this process of access to testing and then to specific treatments, and get that a smoother process? And in fact, I think I'm chairing a group in beginning of next week, I think, or the week after, to actually think through what can we embed for the future, which will help these groups. They're quite disparate illnesses and treatment groups, but ensure that we can support them right from the start of something in a way which ensures they know that they are being considered, as well as the bulk of the population who can probably respond to vaccines as well.
I mean, it has been a grueling couple of years. A lot of people say it's sort of almost vanished. It's sort of time taken away. So it is reassuring to know that there's a lot of learning and information coming out of it that should help us for the future. A couple of questions I'm going to wrap up together because they're quite broad questions, but they're quite important ones too. And they both talk about vaccination status, and one is about how is vaccination status related to continuing deaths from COVID, and the other one's about hospitalization rates for COVID. So is there a relation to being unvaccinated, or how does that play?
Well, I mean, the simple message, it's quite a complex vaccine picture now, because obviously people have had different vaccines. You can see it in different age groups. Obviously, older people have tended to have AstraZeneca, but that's not the case in different parts of the country. Different people have different devolved administrations, for example, have rolled out vaccines in different ways to care homes, for example. So, but when, I mean, there's a broad statement which says if you haven't been vaccinated, you're, which I think is a barn door obvious statement that we can see in the data. If you haven't been vaccinated, then you are at much higher risk of severe outcomes, hospitalisation and death. And that is the key message that runs through this. There is data around where we look at the maintenance of antibody response, for example, and at certain periods after vaccination, and seeing that come through. And that's where I would say, yes, there is a correlation in the sense of as vaccination wanes, particularly in the elderly, then obviously the serious outcomes and hospitalisation increases. But it is much more difficult to be clear on those outcomes now, because we've had a reasonably high number of hospital admissions and hospitalizations with COVID now, but a very high proportion of them are individuals who happen to have COVID and are in hospital. And increasingly, as we get broader population protection from historic vaccines, whether it be a very recent one or one, say, 6 months ago, it's extremely difficult to untangle the differential impact of concurrent disease morbidity from cardiovascular and other respiratory disease and from COVID itself. And I think just one thing, it's quite important, because I've seen this reported in some of the data recently, because there isn't routine testing on admission into hospital generally now, or certainly hasn't been over the summer period. What you will often see in the data is HCAI admissions. Now, they are not all hospital-acquired infections. It doesn't mean that all those numbers have been passed from one patient to another or a healthcare worker to a patient in hospital. It means it is picking up all of those who had COVID brewing when they came in, and individuals who have acquired COVID in hospital. And so really, really important that any data that we're looking at, whether it be vaccination, whether it be antibody waning, whether it be actual simple acquisition of infection, that we think about what the data is telling us before jumping to conclusions.
No, that's a good point, well made. And we're almost out of time. So I'm going to ask Jenny if there's any key message you'd like to leave everyone, but I'm also going to just slot in the question here that's got 2 votes, and it's about hand air dryers in toilets. Should we be worried about hand air dryers in toilets? Is there any evidence that they're a problem? And anything else you'd like to leave us with?
Do you know, funnily enough, I think I was asked that just before I went onto a podium at number 10 one day, and I suddenly sent a message back to base that says, have we got an evidence base on hand hairdryers? And amazingly, somebody had done some work on hand hairdryers, and at the time it was considered not to be a significant risk factor. I think that's the best way to put it. But of course, there is a logic there which says if you point the ventilation system in the wrong direction and blow bugs from an isolation room back into the room, then of course you create a risk. And in some ways, you may well be doing a little bit of the same there. So I think that's one for Professor Kath Noakes to answer in perhaps one of your future sessions.
Okay, all right, well noted. And anything else quickly? Anything?
No, just an absolute plug. You mentioned the twendemic, Jill. I think just encouraging everybody to get their booster. They're all available now for annual flu for those eligible, and COVID, but particularly to encourage pregnant women that we discussed, and those with underlying health conditions to go and get jabbed this year.
Absolutely, really important message. So many thanks, Jenny. Your time is extremely precious, so we do appreciate you taking the time to talk to us today. And of course, thanks to everyone who's joined and for all your questions. And if you're interested in communicable diseases, next week there's a 2-hour event focused on monkeypox.